Welcome to this Pearl of Laboratory Medicine, brought to you by AACC and the Clinical Chemistry Trainee Council. View this and many more pearls, as well as other free educational material at traineecouncil.org.
Hello, my name is Zhang. I am a clinical assistant professor of pathology at Stanford University. Welcome to this Pearl of Laboratory Medicine on immunoglobulin and the T-cell receptor genetics. Here's the outline of this talk. I will cover the structure and the genetics of IG and the TCR, T-B cell development, and TCR-IG gene rearrangement, molecular testing, and the clinical utility of the TCR-IG rearrangement analysis. Let's first review the structure of IG and the TCR. B and T lymphocytes are characterized by their antigen-specific receptors, which are the primary effector molecules of the adaptive immune system. For B cells, there are the membrane-bound form of the immunoglobulin as main component of the B cell receptor, BCR, and the soluble form of IG secreted by plasma cells. Both forms of IG have the identical Y-shaped structure composed of 2 heavy and 2 light chains. On the other hand, T-cell receptors are heterodimeric cell surface molecules responsible for recognizing antigens presented to T cells in context of MHC molecules. In the circulation, majority, about 95% of T cells, express alpha-beta chains, and a minority of T cells express gamma-delta chains as a part of the TCR complex. Gamma-delta T cells are a dominant subtype of T cells found in epithelial tissues. Both the TCR and IG molecules consist of variable and constant regions. Each lymphocyte receptor has a unique antigen specificity determined by the structure of antigen binding sites, primarily from the variable amino acid sequences. At the genetic level, there is a complex and elegant mechanism to generate the remarkably diverse lymphocyte antigen receptor repertoire needed to respond to a great variety of antigens. Each receptor chain variant cannot be encoded in full in the genome due to the extremely high level of diversity. Instead, the receptor chains are encoded in the germline genome in several pieces as a variable V, diversity C, and adjoining J gene segments, with each type of gene segment present in multiple copies. These gene segments are assembled in the developing lymphocytes by random somatic DNA recombination to form a complete variable region sequence, a mechanism known as gene rearrangement. V and J segments are present in all antigen receptor genes, with the D segment present only in some. The large number of possible combinations of the different segments accounts for much of receptor repertoire diversity. Besides, there is non-templated insertion and deletion of random nucleotides at the junctional regions by the enzyme terminal deoxynucleotide transferase. This occurs early in lymphoid ontology in both B and T cells, essentially in tandem with the rearrangement process, and further increases repertoire diversity. Mature B cells, upon encountering and activated by antigens, can extend the IG repertoire through somatic hypermutation, which is a high rate of point mutations in the V regions of IG genes. As depicted here, the rearrangement process for IgH genes usually starts with a D to J rearrangement, followed by a V to DJ rearrangement. The same process applies to TCR beta and the TCR delta genes. IG light chain, IG kappa, IG lambda, TCR alpha, and the TCR gamma genes do not contain D gene segments, and their rearrangements involve direct V to J recombination. The rearrangement process of IG usually starts with a D to J joining, followed by a V to DJ joining, in case of a heavy chain, IgH gene, or direct V to J joining in case of light chain kappa and the lambda genes. The sequences between rearranging gene segments are usually deleted. Antigen receptor gene rearrangement is an error-prone process, and some rearrangements result in non-functional genes. In the case of IgH, if a rearrangement of the first allele fails, the second allele is rearranged. A single B cell may have two different IgH rearrangements. The IG kappa genes rearrange in a similar way only after the successful rearrangement of the IgH gene. In most cases, the IG lambda genes rearrange only if rearrangement of the IG kappa genes fail and both alleles are deleted. Normal B cells that fail to produce a functional IgH or light chain rearrangement would usually undergo apoptosis. T cells develop from common lymphoid progenitor cells that seed the thymus from the fetal bone marrow or liver. The differentiating T cells in the thymus are either double negative, double positive, or single positive for the expression of CD4 and CD8 cell surface antigens. During the double negative stage, T cells can be subdivided into 4 subsets, 1 to 4, based on rearrangement of their TCR genes and the expression of surface antigens. TCR gene rearrangements are more complex and generally follow a hierarchical order. First, the TCR delta chain genes rearrange, then TCR gamma chain genes, potentially resulting in TCR gamma delta expression, are followed by further TCR beta chain gene rearrangement and the TCR delta deletion, with a subsequent TCR alpha chain gene rearrangement, potentially followed by TCR alpha beta expression. The estimated numbers of functional and rearrangeable human VD and J gene segments involved in TCR IG gene rearrangements are shown in the table. The many different combinations of VD and J gene segments represent the so-called combinatorial repertoire, which is estimated to be 2 million for IG molecules, 3 million for TCR alpha beta molecules, and 5,000 for TCR gamma delta molecules. We have talked about the genetics of lymphocyte antigen receptor rearrangement. How would this information be useful in the diagnosis of lymphoid neoplasms? Neoplasms are populations of cells that, in theory, derived from the proliferation of a single common precursor cell, and therefore would be expected to contain identical DNA sequences, which could be used as specific tumor markers. Clonal rearrangements of IgH and IG kappa can be detected in essentially all malignancies of mature B cells. But many precursor B cell malignancies will have only IgH rearrangements. Since malignant transformation occurs before rearrangement of the light chain gene. Rearrangements of the TCR beta and or TCR gamma chains have been observed in almost all types of T lymphoproliferative disorders. However, there are rare T cell neoplasms that lack TRB or TRG gene rearrangement, and in these cases, the evaluation of TRD could be helpful. Although the analyses of antigen receptor gene rearrangement can provide a useful diagnostic laboratory tool for lineage determination, they're not necessarily lineage specific, and cross-lineage rearrangements can occur. Also, clonality does not equal malignancy. Benign and reactive conditions can produce clonal patterns due to antigen-driven lymphocyte expansion. Therefore, results should always be interpreted within the appropriate clinical context and in conjunction with the morphologic findings. So, what molecular diagnostic methods can we use to test for TCR IG rearrangements in the laboratory? Sudden blotting was used in the past, and the method currently used by majority of laboratories is PCR and capillary electrophoresis based. With advancements in sequencing technology, some labs have transitioned to next-generation sequencing-based methods. I will introduce each of these methods in more detail in the next few slides. The applications of TCR IG rearrangement testing include clonality analyses and minimal residual disease assessments. In the past, clonality was primarily studied using 7-blotting analyses, which used to be considered as a gold standard for such testing. This method generally takes advantage of the combinatorial repertoire of TCR IG genes to detect the genetic rearrangement based on reproducible sets of DNA fragments generated by a specific restriction enzyme. To perform this type of testing, high molecular weight DNA is needed to be digested with restriction endonuclease enzymes and electrophoresed overnight in agarose gel to separate the DNA fragments. These fragments are then transferred and hybridized with labeled DNA probes homologous to the target genes. A clearly visible labeled band is detected when clonal gene rearrangement is present. This method generates fewer false positive results compared to PCR. However, there are disadvantages inherent to 7-blotting, such as limited sensitivity, significant demands in time and technical skill, the need for large quantities of high-quality DNA, longer turnaround time, and not suitable for tracking clones. Compared to 7-blotting, PCR-based method is faster, more accurate, and requires only small amounts of DNA as template. In addition, PCR can also amplify partially degraded DNA. Therefore, PCR-based techniques can be used to analyze small biopsies, for example, skin biopsies, or formalin-fixed paraffin-embedded tissue samples, which generally yield low-quality DNA. Two different types of PCR analyses are used for TCR IG gene rearrangement assessments, qualitative and quantitative. Qualitative assays are suitable for clonality assessment and do not allow for precise MRD assessment. The PCR amplicons generated using TCR IG specific primers then undergo capillary electrophoresis to be separated by size. The interpretation of clonality is based on the fragment size distribution pattern. Representative monoclonal and polyclonal patterns are shown on this slide. Quantitative PCR-based approaches are important for assessing treatment responses and monitoring MRD prior to availability of NGS-based assays. TCR IgG rearrangement analyses using next-generation sequencing technology started to become available in clinical molecular diagnostic laboratories in recent years. Compared to PCR capillary electrophoresis-based methods, NGS-based methods can provide the fingerprint characterization of each clonotype, namely the specific rearranged sequence, as well as quantitative sequencing count information. It can improve the test sensitivity and specificity compared to PCR-based methods. The test can be readily performed on a benchtop sequencer with the capacity to multiplex several samples in the same run. Some major clinical utilities of molecular TCR IG gene rearrangement analyses in lymphoid malignancies are listed here. It can aid diagnosis of challenging or inconclusive cases of lymphoproliferative disorders, evaluation of a clonal relationship between two or more lesions in the same patient, discrimination between a relapse and a second malignancy, lymphoma staging, and the monitoring evaluation of treatment effectiveness. To summarize the main points of this scroll, TCR IG genes are encoded in the germline genome as different gene segments. During TB cell development, the V, D, and the J gene segments undergo random recombination to form complete sequence, known as TCR IG gene rearrangement. Additional non-templated nucleotide insertions and deletions at the junctional regions during gene rearrangement, as well as the somatic hypermutations in IG genes, further increase TCR-IG repertoire diversity. Molecular analysis of the TCR-IG gene rearrangements has important clinical utility in diagnosis and monitoring of lymphoid malignancy. Thank you for joining me on this Pearl of Laboratory Medicine on immunoglobulin and the T-cell receptor genetics.
For more like this, as well as articles, podcasts, and more, please visit the Trainee Council at traineecouncil.org.